Welcome to the St. Francis Hospital High Performance CPR Directive online training. This directive has been approved by the Directives Committee, ALS Coordinator, and the Chief of EMS. This directive was developed in accordance with national and state protocol and is based off of the information presented at the Resuscitation Academy, a national organization dedicated to improving the survival rates of victims of cardiac arrest. If you have any questions regarding the implementation of this directive, please contact the on-duty supervisor. By now you've likely heard of Pit Crew CPR. This directive is heavily based off of that concept and lessons learned from the Resuscitation Academy. High Performance CPR is all about increasing patient survival by decreasing downtime and breaking old habits. Though there has been some pushback in the EMS community, studies are consistently showing that high performance CPR works. Dr. Rosenbaum said it very well in response to a provider who was complaining that he had done CPR the same way for 30 years and didn't want to change it now, in saying that, well, we've been killing people the same way for 30 years. Change may be difficult, but it's very important. High performance CPR requires that providers realize compressions are king in cardiac arrest. Minimizing time off the chest is essential, and we will be discussing ways to do that today. Along with realizing that compressions are king, we need to emphasize the fact that teamwork, communication, and consistency are essential to success in this program. It doesn't get much clearer than this. The survival rates of CPR patients drastically drop after 10 seconds of interrupted CPR. It is critical that we minimize interruptions to chest compressions and ventilations. We also have to fix the errors that are causing poor compressions. These errors include unnecessary patient movement, provider fatigue, posture, inappropriate placement of the patient, and the inappropriate use and placement of equipment. For example, not clearing the space around the patient of first-in bags and tools can hinder a provider's ability to move freely and smoothly when rotating in and out of roles. So can leaving a patient on a soft surface, such as a bed. Looking more in depth at the details of the research on high-performance CPR shows that there is no reason to go back to the old way of doing things. Though spikes and drops do appear on this chart as the EMS community acclimated to the program, there is a general upward trend in survival rates over the last several years. That is the main takeaway from this graph. We should not be discouraged by the drops, because again, they are simply the community getting used to the new program and its format, as well as other factors that may have been out of the provider's control. When we look at the 7 mantras of the Resuscitation Academy, we see the following things. When we say measure and improve, we need to find out what we're doing wrong and how we're going to improve it. The second mantra is, if you've seen one EMS system, then you've seen one EMS system, and that's very simple. No two EMS systems are exactly alike, and that's all the more reason why we need to have a simple, standardized method of performing CPR. The third mantra is, it's not complicated, but it's not easy. Old habits die hard. We need to practice and really try to make this happen. The fourth mantra, change occurs step by step, is very simple too. It all starts here with this PowerPoint and with this training. The more that we work on this, the more we're going to improve. The fifth mantra is performance, not protocol. We can have all the PowerPoints we want and all the trainings we want, but it won't mean anything if we don't actually apply this. The sixth mantra is everyone in VF survives. Effective CPR can extend the time that a patient is in VF, and it's the only way for a patient in arrest to have a chance at survival. The seventh mantra is self-explanatory. It takes a system to save a patient. It's teamwork, plain and simple. Some of this presentation may seem redundant, but if you find something is being repeated frequently, it's for a reason. As stated earlier in the presentation, the longer a provider has been in EMS, the harder change seems to be to take. Old habits die hard. The general concepts include things like hovering your hands over the patient's chest anytime you are preparing to take over compressions, and anytime the AED is analyzing for a rhythm. This will be demonstrated later in the presentation. There are exceptions to every rule, of course, and this program is no different. As much as we would like to work the patient where we find them on every call, we have to consider danger to the providers, tight spaces, and other factors, which will be addressed later on. Many providers may not want to hear this, but it's important to note that if a metronome is available, it should be used. Paramedic Scott Keir of Newcastle County EMS has a habit of telling providers that the best way to get rid of that annoying metronome is to get ROSC. Use it as motivation. In the meantime, it does nothing but improve CPR quality. All CPR responses and suspected CPR responses will follow this format unless the call is downgraded. The first responder in the door starts compressions every time. The second responder can bring in the gear and apply the AED pads. CPR should be continued until the AED is ready to analyze. Hover the hands over the chest while the AED charges or analyzes the patient. It's important to remember not to hyperventilate the patient. Squeeze 1/4 of the BVM over 1 second. Count in your head 1 Mississippi. Providers will switch compressions every 2 minutes, regardless of how the provider feels. Or you can switch earlier if compressions are poor. It's important to communicate. Do not be offended if someone needs to take over. It's for the patient's best interest. Coordinate the rotation of the providers. This means in advance, or when you arrive at the patient, decide who is going to move and where they are going to move. A suggestion would be to have all providers move in a clockwise motion every time the AED analyzes. So the person from the head goes to the chest and so forth. The provider at the BVM coaches the provider giving compressions. Make sure to mention placement, depth, and recoil. Recoil is a very important part of CPR and it's often neglected, especially as providers start to get tired. Remember that ALS works around BLS. We can do the things like keeping time and paying attention to quality compressions and ventilations. Let them work around us. Remember that the total time off the chest each minute cannot exceed 12 seconds per cycle. That includes time for shocking, moving the patient, and transitions of providers. Dr. Rosenbaum said at the Resuscitation Academy, quote, "There is no magic in the ED that I can perform that can't be done in the field." Remember that whenever possible, the patient should be worked where they are found. It has been noted in several studies and in Newcastle County that movement of the patient in the ambulance when they are still in cardiac arrest brings the patient's chances of survival to almost none. Remember what your FTO told you. I'm not inside your head. Communication and verbalization are everything. The person performing compressions should count the 8th, 9th, and 10th compression in each set of 10 out loud. This allows the person using the BVM to know when they should deliver a breath. When the AED suggests a shock, complete 30 compressions, remembering to count 8, 9, 10, 8, 9, 20, 8, 9, 30. On that 30th compression, they should hover their hands over the chest in order to clear the patient, and then immediately start compressions again after the shock is delivered or if no shock is advised. If ALS is not available when a shock has been delivered, continue CPR until obvious signs of life are present. Remember that our goal here is to minimize the time off of the chest. CPR is not going to kill your patient. Wasting time with pulse checks and I'm not sures can. Another way we're hurting our patients is by letting our pride get the best of us. If someone says, I'm good, but their CPR is clearly poor, they need to be moved out of the way and transitions need to happen. It's that simple. Pride kills patience. The after-incident review is a debriefing following any Priority 1 patient. This is not meant to be punitive, and there will be further training rolled out on this at a later date. The information from this directive will be used to improve EMS responses. Notes should be sent to the on-duty supervisor for record keeping and QA/QI. It can involve BLS, ALS, and fire if available. The format is simple: sustain, improve, etc. Mention one good thing, mention one thing we might be able to change. We're not directing things at people individually. We're just saying what we could do better and what we should continue to do. To make things simple, this can be directed by the highest ranking person in the room, or the first responder, then the second responder in, and so forth. The only way for us to really improve is if we are honest with ourselves, and so it's imperative that we take this seriously. A lot of folks are concerned that this isn't going to work with ALS, and very simply, they're wrong. It will work with ALS, and it is working with ALS. Chief Tan of Newcastle has said it, Sergeant Aber said it, paramedic FTO Scott Keir said it. BLS owns CPR. There is no if, and, or but about it. We own CPR, and we should direct the way that it goes. ALS knows this, and they are going to assist us in that. They are here to help us, not move us around as they see fit. This doesn't mean that we should argue with ALS over their protocols. It means that ALS knows what we are supposed to do, and they are going to allow us to do that. This idea is coming down from Newcastle, and we have the full support of their leadership to make this happen. There are no excuses. CPR is a team effort. ALS can work with and around BLS to complete advanced life support procedures. On the next slide, we're going to see a demonstration of 3-provider BLS CPR. Please note that this department uses continuous compressions during all CPR. That will be shown in a video following this one. Remember that we do not do a 30-to-2 ratio. We give one breath on every 10th compression. We give that breath on the upstroke of the compression, and we do so by squeezing 1/4 of the BVM over 1 full second.
Check for pulse. Sir. No pulse. Start CPR.
Apply pads. Plug in pads connector next to flashing light.
Okay, we got about a minute and a half of CPR left to go.
Count it out for me there.
28, 29, 30.
Yeah, he's bagging
Apply
good. I got
pad.
good respirations on that one.
Plug in connector.
20, 7, 28, 29, 30.
2.
Okay,
He's
clear
still
off
bagging
Mario.
good.
We'll analyze after this set.
Plug in connector.
Check for pulse one more
20,
Ephemerals with compressions.
26, 27, 28, 29, 30.
Okay, clear. Analyze.
Apply pads. The patient stay clear of patient. Analyzing. Stay clear of patient. Shock advised.
Shock
Shock
ordered.
delivered. Begin CPR.
25, 26, 27, 28, 29, 30.
1, 2.
Okay, Andrew, one more respiration and then you'll clear off.
Okay.
Twenty-six, 27, 28, 29, 30.
1, 2.
After this set, we'll analyze Mario.
Stop CPR. Stay clear.
Have a strong
of
femoral
patient.
pulse with CPR.
Begin CPR.
26, 27, 28, 29, 30.
Hover.
Stay clear of patient. Analyzing.
Hover.
Shock advised. Stay clear of patient. Deliver shock
Continue
delivered.
CPR.
Begin CPR.
20, 26, 27, 28, 29, 30.
Felt good respirations on that.
Eight, 9 bag. 8, 9 bag. 8, 9 bag.
Still easy ventilations.
8, 9, bag. 8, 9, bag.
There are usually 1,000 what-ifs in a presentation like this, and while it's impossible to discuss each one of those, we should make mention of the special circumstances like patient movement, awkward and small spaces, trauma arrest, drug overdose, and pediatric CPR. While the focus of this presentation is not on pediatric CPR, the major tenets of this program will work with it. Remember that if the family is not allowing you to perform CPR, or if they are putting you in danger, you must move the patient. But you really need to consider if they are stopping you or if you just don't want to listen to them. Remember that the patient's life depends on you working there on scene. So if you are not in danger, you should make every effort to stay there. The same applies with a drug overdose, any kind of awkward or small space, and any patient movement. If you are able to effectively complete compressions, you should leave the patient where they are. Remember that with a trauma arrest, we load and go. We never work a trauma arrest on scene. Any further questions that you have in any CPR should be directed to the highest trained provider on scene, the supervisor, or medical control. It is also important to mention that whatever decision is made, especially when it comes to moving a patient, that movement and that decision should be made as quickly as possible. It is essential to minimize downtime without compressions. Thank you for viewing this presentation. I hope that you have taken something from it. If you have any questions, please contact your on-duty supervisor or contact me at dteague@che-east.org for any questions about the presentation itself. Remember that this directive is only worth it if we actually use it as a department. Try and make every effort to practice this whenever you have an opportunity and to spread this information as you come across new providers.